So, again, when I made this request to talk about this, what I wanted to do is kind of go over how a program of research is built. And then we can figure out, where you are and how to collaborate and how I can best support you moving your program of research forward. Okay. So we're starting out, quite honestly, with, I would say, one of my favorite models. And this is something called the Orbit model, and it's from the National Institute of Health. And the reason I like it so much is when you think about us as nurses, usually what we're doing is we're working towards intervention development. And I heard from two of you, which I was very excited to hear, that you've done like a systematic review, you've done some qualitative work, and now you're looking at how to move forward with intervention development. So this is a very, very good model for you to take a look at. So when we start out, we need to first identify a significant clinical question. And as nurses, we usually don't have a problem with that because we're surrounded with significant clinical questions. However, when we are starting to move to research, what we have to do is spend some time defining and refining our question. And this is when we do our systematic review. Because a systematic review, what it does is that it helps us define what is known and also lets us know where the gap is. So we're really defining and refining our question, our significant clinical question, with phase 1 design, and often that is done with a systematic review. Then what we do is we look at phase 2, which is preliminary testing, okay? And this is when, once we know what's in the literature, what has worked, what hasn't worked, what are the gap, then what we do is we want to do the preliminary testing of an intervention that we think might work. And then that's really when we do like our proof of concept. And the proof of concept is often thought of acceptability, feasibility studies. That's really where the proof of concept is. Is the study acceptable? And usually with acceptability, we often take a look at having two different ways of review. We look at often, number one, our most important people are our patients. So we have patients take a look at our intervention and they go, yeah, maybe this is okay. Or they go, that doesn't work so well. And then we also usually have a review by experts. So content experts. So that's really our proof of concept acceptability. And then feasibility is, can we deliver this intervention? Okay. So with feasibility, often what we're looking at is, can we recruit patients to the study? Will they go through the study procedures? So feasibility is all about, conducting the study and can you do it? Then often what we do for phase 2 preliminary testing, often what we do is a small pilot. With a small pilot, what we're doing is often we're looking at preliminary effects. Often with a pilot often has also some feasibility aims with it sometimes. But with a pilot study, we're just making sure that we can do it, and then also whether or not we have a suggestion of an effect. Is there a trend towards an effect? Usually with a pilot study, it's not powered to get a full answer of whether or not the intervention has an effect. So once we do this phase 2 preliminary testing, then we move to phase 3, which is a randomized clinical trial. Okay, and let me back up a little bit with the pilot. Sometimes with our pilot, and I would say, I can't say the majority of the time, but I would say a significant number of pilot studies are single arm, because really you're just interested in seeing, can you show that you can do this study, and you want to show, is there a preliminary suggestion of an effect? And so it's a pre-post study design or a single arm study design. So when you get to the phase 3 or effect trial, does this trial have an effect? Then it's a randomized clinical trial. Because the randomized clinical trial is what we like to say the gold standard of whether or not this intervention has an effect. So it's fully powered, and it does a good job with showing yes or no, this intervention has an effect under well-controlled conditions. And then this orbit model ends with effectiveness research, but here in this talk we'll go further, because after effectiveness comes implementation dissemination research. So I'll talk about that. But the orbit model really only goes up to phase 4, which is effectiveness research, which is a pragmatic clinical trial, is what effectiveness research is. So with a randomized clinical trial, it's, does this intervention have an effect? With pragmatic clinical trial is, does this intervention work in real world settings, in a regular clinical setting? So I really like this model, the orbit model, because you can see how it lays out exactly what steps you need to do as you move towards intervention development and then intervention testing. So I'll pause here and ask if there's any questions about this orbit model, and I can send you the reference. I should have sent you the reference and the article so that you can share it with everybody. Any questions about the orbit model?
I have a question to clarify about effectiveness research, because sometimes even we go into like methodology, they did the research like randomized control trial, but they claim this one is an effectiveness of the research of this intervention.
Correct. I would say that when you read the literature, most people are not so specific with their language, in that effectiveness and efficacy are often interchanged. If, however, you want to be very precise with your language, if they're doing a randomized clinical trial, they're not showing effectiveness yet. They're only showing whether or not the intervention has an effect. But yes, I would say when you read the literature, the language is messy and not as clear cut. Yep. Yeah. Good. Very good point. Yeah.
I have a questions about as you mentioned about suggest effect size from the pilot study.
Yeah.
Would you mind to clarify a little bit about how to get suggest effect size and how to use it in the randomized control trials?
Yep.
Thank you.
Yep. So looking at powering, okay, if you're powering for acceptability, feasibility, or a pilot study, okay, then there are different calculations to determine the number of people that you need in the study. If you're powering for showing an effect of the intervention, okay, then what you're doing is you're taking your primary outcome variable and you're looking in the literature to see an intervention that is maybe similar to yours that was done in a different population and taking a look at how many people they needed to show a difference between the intervention and control. And that is what is the effect. Another way to look at it is the effect size of the intervention. So something with a small effect size is 0. Hopefully you don't have 0. That means your intervention doesn't work at all. So, but 0 to 0.4 is considered small, or 3.9. 4 to about 7 is considered a medium effect size. Most nursing interventions have a medium effect size, or I can even say most behavioral interventions have a medium effect size. Honestly, if you have an effect size of 0.5, that's pretty good. That's actually pretty good. It is highly unusual to have a large effect size of 0.72. Of course, 1 means everybody, gets an effect from the intervention. In real life, no one has, that amount of a 1, where everybody has an intervention effect. Yeah, because we're people and we're all different. So, that perfect doesn't have. So, thank you again for that question. So, how you determine the power and the effect size and how many people you need to have in the study is going to be a little bit different for if you're doing a pilot, feasibility, acceptability, if you're doing an RCT, or if you're doing effectiveness or a pragmatic clinical trial. Yeah. But with a RCT and a PCT, what you're doing is you're looking at the effect size of the intervention, and empowering off of that. Yeah. Did that answer your question? Oh, do you want to ask a follow-up question? Because I covered a lot of things there. So yes and no for what you're saying. So let me explain. If your intervention, and is it okay if I use your research as an example? Okay. So you're looking at the mind diet and you're looking at exercise, promoting exercise. Okay. There is effect sizes for the mind diet, okay, on dementia. There is also effect sizes for exercise on dementia, okay? But there may not be effect size, or there may not have been someone who has done an effect size for both the mind diet and an exercise intervention. So after you do your pilot study, okay, in order to calculate your sample size for your randomized clinical trial, what you want to do is look at the effect sizes of the published research on the mind diet, the effect sizes of the exercise, And you also want to use your pilot study effect size with exactly what you just said. So I was very happy you said that, saying that because this was a pilot study, it's an overestimation. So you would take the effect sizes of all three and kind of put them together to say, well, we expect an effect size, and I'll just make up numbers. Is that okay? Okay. So for the DASH or for the MIND diet, let's say the effect size is 0.45. Okay. For exercise, the effect size is 0.5. Coming from your pilot study, it was 0.6 because it's an overestimation. Okay. So you're looking at anywhere from 0.5 to 0.6. So when you calculate for your randomized clinical trial, what you want to do, and this is a good way to do it, is make a grid, okay? And you say, if conservatively, we can say we will at least have an effect size of 0.45, because that was the lowest effect size with only the MIND diet, okay? But we're also having exercise, and that effect size was 0.5. And then our pilot study showing the two of them together was 0.6. So we can hypothesize based on this. Our range is from 0.45 to 0.6. If we choose a conservative 0.5 or 0.55, okay, this is how we calculate our effect size. So that's the way I would do it. Okay, excellent. Other questions before we move on? And this is really supposed to be a discussion. So it isn't supposed to be just me a lecture. So really interrupt often. And because this is really just some slides to start a conversation. Yeah. Okay. In general, when you do your consort diagram, so that's the flow of the study for a randomized clinical trial. For a randomized clinical trial, we follow the consort guidelines. Okay. For the consort, what you want to do is you want to say how many people have withdrawn between when they were recruited and signed the consent form to when they were randomized, and then from when they started the intervention to when the intervention ended to the follow-up. Okay. If a participant withdraws from the study or lost to follow-up, okay, then you want to put that number down. The discontinuation is when the investigator makes the decision that they can no longer continue. Okay, and this is where it gets a little bit tricky, and I'm not sure. Your question is it necessary? Most of the time in the consort diagram, we do not differentiate, make a different call between who the patient withdrawing from the study, saying, I'm not interested anymore, or just not responding anymore, lost to follow-up, and the people who the investigator says you can no longer continue. Usually we just put down the reason. We usually just say lost to follow-up. The reason you may want as an investigator to end someone is if they're hospitalized, okay? And you know that, they're no longer going to be able to complete the study procedures. That would be an investigator. But usually in the consort diagram, we just write down the reason and we don't make the differentiation between the two. Did that help? Did that answer that question, or do you want to ask a follow-up question for that? So the main way to differentiate the two is the withdrawal is the patient reasons. The discontinuation is the investigator reasons. So what would the reasons be for you as an investigator to say, I'm so sorry, but you cannot continue anymore? Okay, so I mentioned hospitalization. For me, also, it would be if they develop, well, okay, if they have a serious surgery, they aren't going to be able to do the exercise. So then they may want to continue with the study, but you as an investigator say, I'm really sorry, but you can't exercise because you broke your leg and you just had surgery, so you cannot continue anymore. So that would be an investigator discontinuation criteria. Another discontinuation criteria that I use an investigator is if they have a serious mental health issue. Okay, so if they have a schizophrenic break, okay, if their dementia increases to the point that, okay, like my father-in-law, we were talking about, he's on his dementia journey. Well, okay, we'll go back to my mother-in-law. When she went from moderate or from mild to moderate, she was still kind of okay. When she went from moderate to severe, she wouldn't be able to do the study anymore. That again would be a discontinuation criteria as an investigator that you would use. Did that help? This is a really, really good, this is a lovely discussion. Okay. Well, I'm a very strong methods person. So this is exactly the questions I like because I think about methods. With a randomized clinical trial, a good one, you have what's called intent to treat. Okay? With intent to treat analysis, the saying is once randomize, always analyze. Okay? Intent to treat analysis. Once randomize, always analyze. So with an intent to treat trial, there is even if they only come to one session, you have to keep them in the study and analyze. Even one, even none, actually, even none. Once you randomize, you have to always analyze. Okay? Now, for a pilot study, what you can do, and even for a randomized clinical trial, what you can do is make a definition that says that they have to, per protocol, attend 70% of the intervention sessions. So you must analyze using intent to treat with the randomized clinical trial. You're going to get rejected from any good journal if you don't do an intent to treat analysis. But then you can also do a per protocol analysis, which is you only analyze the people who attended 70% of your intervention because that is a priority. So before the study started, a priority, your definition of what a full dose of the intervention is. Okay, so that's a second analysis, is a per protocol analysis. The next analysis is a dose analysis. If you don't really know, okay, what dose will show an effect, then rather than a priori before the study starts, say 80% is our definition of full engagement, okay, with the intervention. And I use the word engagement very intentionally. I don't like adherence. I like engagement, okay? If you really don't know what full engagement means, i.e., if that will show a clinically meaningful difference. And again, here I'm being very careful with my language. A clinically meaningful difference is different than a statistically meaningful difference. Okay? We really only care about engagement with the intervention as it relates to clinically meaningful difference. Okay. Then I would suggest doing a dose analysis where you look at how much dose you need in order to get a clinically meaningful difference. For the protocol that you're submitting to IRB? No, but just for publication. I would only include that if you know from published literature what dose or what engagement looks like for your intervention. If you don't know that, I wouldn't make an a priori or before you run the intervention determination of what is full engagement. Generally speaking, in general, if you want to put something in the protocol, usually it's 70% is what is considered to be good engagement with the intervention. And moderate engagement, again, would be from 40 to 70%. And low engagement is 0 to 30, or 0 to 40, I should say. So that's usually how low, medium, and high engagement is labeled. Yeah. But again, I would only put that in if you know from the literature. And the problem is that a lot of the literature doesn't break that out and tell you how engaged people are. I think some of the really high quality journals, you'll find that information because it's a requirement for like JAMA. You have to write that down. But our nursing journals usually don't require that. So that will be a little bit harder to find. So now we're going to talk a little bit about the different pieces of the orbit model. So this is really where you should start, is systematic reviews and meta-analyses. And if you know your intervention, so I would take a look, and especially when you're looking for your effect size, that hopefully there's a meta-analysis about the mind diet. Hopefully your exercise intervention isn't as specific. So you probably aren't going to find a meta-analysis to match your exercise intervention, but the mind diet you might. And for the meta-analysis for the mind diet, you might find, hopefully you will find something, related to cognitive impairment, which is your long-term outcome. So when you do this, systematic reviews and meta-analysis, systematic reviews, of course, will tell you the state of the literature. Meta-analysis are really nice because then you get a better idea of the effect size of the intervention that you're specifically looking at. Now, someone was doing a systematic review. Can you tell me more about your systematic review?
Yeah, I conduct systematic review about evaluate health education, dietary behavior, and physical activity. Yeah.
That's very helpful for you. So were you able to do a meta-analysis at all? Were there enough studies, or a mini meta-analysis? Were there enough studies that were using similar interventions and similar outcomes?
Yep. I have, for example, for diet, I think I have around 4 intervention that have met with same intervention and same population, because I focusing on people with at-risk hypertension and people with hypertension. Yeah.
Okay. So if you're doing hypertension, then you're doing the DASH diet?
Yes.
Yeah.
I include DASH diet and includes some intervention that they said sodium restriction, something like this. Yeah. Not just only focus on DASH diet. Just
Okay.
include if they put about related with hypertension. Yeah.
Okay. Okay. And tell me a little bit more about the exercise interventions.
Yeah, for exercise, they have I just classify about moderate intensity, high intensity, and some exercise they have endurance. And then I just put subgroup analysis for classify if they have moderate. I just put to do meta-analysis for them. Yeah.
And then so your question to me was, how do I move from the systematic review meta-analysis into an intervention? So you tell me, what was, from your meta-analysis, what was your effect size for the DASH diet or diet studies?
Wait a minute. I forget already. I will look at my paper.
Yeah, thank you.
My paper. For DASH diet, for dietary intervention, effect size is 8.32. That's correct or not? I'm not sure.
Point.
If I can choose my forehead pot, can I show my forehead pot, or what do you think?
Probably not, because I don't have technical support here for you to be able to show it. Sorry about that.
Okay, no worry. When I look at my forehead pulse for systolic blood pressure and diastolic blood pressure, the mean difference from two intervention, they can decrease systolic blood pressure 8.32.
Try to play. Okay, there we go. I got it. Thank you. So one of the ways to move forward for you then is, based on this, you can take a look at which intervention was more effective.
Which intervention? The intervention that they encourage people to drink tomato juice. Yeah, they have intervention like every day they give patient with hypertension to drink tomato juice every day. Yeah.
Okay.
Yeah, but then they can decrease systolic blood pressure 7.88 millimeter mercury.
Okay. Yeah. Has that study been replicated at all, and where was it done? And how big of a sample size was it?
Sample size is small. Sample
That's what I
size is
thought.
only 14.
Yeah. So I would, when looking at your career, a sample size, well, as we heard, a small sample size means that the results that is being reported is extra generous and is probably an overestimation of the results. So I would not, looking at my future career, I would not be recommending that diet unless it had been replicated in a larger sample.
Yeah, I got this part. Yeah, because it's small sample size, just only 14.
Yep. So that's not a reliable, okay, it's an overestimation of the effect of that intervention.
Yeah.
But getting back to what I was talking about is what you then use with your meta-analysis is that you can figure out which interventions have the best evidence and the most effect, and that's what you want to move forward with. Because, of course, we as nurses want to promote the best evidence-based practice. And that's how we move from a systematic review or a meta-analysis to then planning our intervention. Does that make sense?
Yeah. Yeah. When I look at my when I look at my result, the intervention is endurance exercise have a good effect.
Yep.
Endurance exercise can decrease systolic blood pressure. I got four intervention.
Yeah.
They can overall effect size is can decrease systolic blood pressure 15.
Okay.
For diastolic blood pressure can decrease 2.5. Yeah.
Okay. Yep. Got it. So that's why starting here with a systematic review and meta-analysis will let you know what is known in the literature and how we can support the best evidence-based practice or interventions that will have the best effect for our patients. So that's why we start here. Yeah.
I have a question. So if I read this paper, and so I just thought like sometimes the study it's not collect the data as in Thai people, shall we replicate the intervention?
Excellent question. And this is so much. Okay, so you have to tell me. Oh, yeah, thank you very much. That was very helpful. You have to tell me why you think you have to replicate it in Thai people. What is it about Thai people that is different, significantly different than the people it already has been studied in?
So it's some things about the race ethic, like Asian people with our body composition and the diet.
Yes. So for diet, I would say yes. Okay, so when we were talking, I said, okay, for the mind diet, you have to adapt it for the culture considerations of the Thai. If you came to me and said exercise, I would say, no. For an exercise intervention, you can't convince me, okay, that an exercise intervention is that significantly different in a Thai person compared to other people for the necessity of replicating. So when you think of whether or not it needs to be replicated, you have to think about, okay, what about the Thai person or the culture context or whatever is significantly different that warrants the time and effort for replication? And often the answer is no. Really. I mean, diet, yes, very clearly. But often when they say, well, we did this, in this population, and then we need to do it again because it hasn't been done in this population, and I go, no. You haven't convinced me why this population is that much different that you can't take the evidence that's already there and just go ahead with doing that intervention in that population. Yeah, good questions. But yeah, for you, you have to do it because it's diet. For the mind diet. So now we're moving to the next step of the model, the acceptability and feasibility. And I put some research aims here because that I thought would make it a little bit more clear what acceptability and feasibility looks like for the aims. So aim number 1, okay, is evaluate the feasibility, okay, can you do it, of study procedures. And this would be recruitment, screening success, retention, attrition rate, reason, weekly computerized, this is a weekly computerized intervention for memory for breast cancer survivors. I jumped right into the aims and didn't give you the context. My apologies. So let me back up to 30,000 foot and give you the context first. Breast cancer survivors usually get chemotherapy. What comes with chemotherapy is something called chemobrain, okay, or cognitive impairment because of the chemotherapy. And so what we need to do then is try to enhance the memory of those who are receiving chemotherapy. So this was a computerized working memory, which is a type of memory retraining program for women with breast cancer receiving chemotherapy to hopefully help with some of the memory problems that come with chemotherapy. Okay, now that I've given you a context, now I'll go to aim one again. My apologies, please forgive me. So there were weekly computerized interventions on the computer and then coach phone calls. So you can see for feasibility, what our hypothesis was that greater than 80% of patients approached will agree to be part of the study. So if we approach a patient in clinic, and we approach 100 patients, 80 patients say yes. Okay. Now, that's high. 80% is a high yes rate, quite honestly. However, what we knew was that women with breast cancer were very, very bothered when they had chemobrain, when they had the memory problems. It was a symptom that caused a lot of distress. And so we actually had most women say, if you can help me remember where I put my car keys, if you can help me remember that I needed to pick up my children from school at 2:30 or 4 o'clock, if you could help me remember recipes, if you could help me remember, my work and be able to do my work well. So that's why we had such a high rate of those who we approached agree. Then here we go. Hypothesis B is less than 20% of patients enrolled will drop from the study. Okay. Then what we did was we broke this out because we also, this gets to your question, we frame this as acceptability specifically with the intervention, okay, or engagement is another word that you can use. And so here, you can also look at fidelity is another word that we have been talking about. But here we framed it as acceptability of the intervention itself. So what we did here was the acceptability for the participant of this adaptive computerized working memory retraining intervention. And this was, we looked at the acceptability because we wanted to know how burdensome it is. Here we are using adherence. Okay, but I already said I would rewrite this now and say engagement to the training schedule. And then the performance level achieved, because this computerized program helped them increase in their working memory and satisfaction. So here you could see the hypothesis is greater than 80% of participants will complete. And here it's all 30 working memory sessions. And each session was 35 minutes each, 5 days a week over 6 weeks. So when you asked me about, defining engagement or fidelity to an intervention, this is when you do it, is when you're doing acceptability, feasibility. Okay. Not so much with a randomized clinical trial, because you should have that information really before you go into a randomized clinical trial. Then keeping with this same population and study, what I'm going to show you is like pilot study aims. Okay. So here what we're doing is we're evaluating the difference in post-test means at T2, okay, at time 2, which was week number 7. You want to adjust for baseline measures. And the reason being, the reason in a pilot study why you want to adjust for baseline measures is because often what you're doing is pre-post test with a pilot study, or if you're randomizing, you're not randomizing enough to be able to have equal groups. So you have to control for that baseline measure. In a pilot study, that's much more important. So, and a lot of, let me not get into all these different, because these are all different working memory. WAIS is, the different working memories. So let's skip over that because that really doesn't matter. And here we have the important part, which is between the intervention, and here we did have a weight control group. So we did have 2 groups here for this pilot study. And our hypothesis is, and this is really important, this is what makes it a pilot study. It says a trend of improved post-test scores. Okay, so it's not that there will be a significant difference. It's a trend, a hint that this will make a difference. Okay, so that's what we're looking for in pilot study aims. So I'm going to pause here. Any questions about the aims for acceptability, feasibility, or pilot study? There can be other acceptability, feasibility aims, but those are, a couple of examples just to give you an idea of what acceptability, feasibility aims can look like.
Professor, I have a question.
Good.
Sorry, yeah. If I need to look at acceptability, feasibility of my intervention, and I also need to measure blood pressure and health literacy. It's gonna be pilot study or feasibility study.
Say that one more time.
Yep. I have conduct. I need to measure acceptability, feasibility, and blood pressure outcome.
Okay.
Yep. And my research is yep.
Yep. If you're measuring blood pressure outcome, okay, then you're doing a pilot study. Because that is not acceptability, feasibility aims. We're not interested in measuring an outcome, a change in outcome. We're not looking at a change in outcome when we're looking at acceptability, feasibility.
Okay. The main thing is if I need to evaluate outcome, that's gonna be pilot study.
Correct. That's exactly right. You got it figured out.
Thank you.
Yeah, you're really welcome. Good question. So you can have acceptability, feasibility, and pilot outcomes in one study. but you have to be very clear about what are your aims. So you can have an acceptability, feasibility aim and a pilot study outcome. However, usually a study is acceptability, feasibility only. And if you're looking at a change in outcome, then it's usually a different study. Because acceptability, feasibility is a much smaller sample size, and you're really looking at just, can you do this, which is the feasibility, and acceptability is, are the patients going to be okay with this study? So the research questions are a little bit different.
Yeah, thank you.
Yeah, good question. Okay, so once you have determined that you have acceptability and feasibility, and I'll go back to, if I may, the question of whether or not you have to do it again and replicate it in the Thai population. If there is, so we talked, I'm going to keep picking on you, my apologies, because we talked about her studies, so I'm a little bit familiar with it. Okay, so the MIND diet has to be adapted for the Thai population, okay? But we already know the effect size of the MIND diet in another population, okay? So what we were talking about is just doing the acceptability part of the MIND diet by doing the cultural adaptation and then going to patients and saying, does this look okay for you? And also going to a nutritionist and saying, you know, these adaptations to the MIND diet based on what foods we have in Thailand, as an expert opinion, is this okay? And once you have determined that, you can maybe move right into a randomized clinical trial, because we already know in other populations that the MIND diet has an effect on mild cognitive impairment. So that's kind of the speedy way to, yes. But you would have to make that argument. You have to say there is clear evidence in other populations that the MIND diet has a proven effect on improving cognition, which there is. There's meta-analysis on the MIND diet, you know, for dementia and that proven effect. So then what you do is you say, so we would expect to see the same effect in Thailand, but we do have to do these cultural modifications because of the diet. So with then the expert nutritionist and the patient saying, yeah, this would work for me, then you can move into the randomized clinical trial. Okay, now I'm going to spend a little bit of time talking about pragmatic clinical trials, because that's our next step as we're moving from randomized clinical trials to pragmatic clinical trials. And for those of you who were here yesterday afternoon, this is going to be a little bit of a repeat, but not all of you were here yesterday afternoon. So I'm going to go over this information, and for those that this is a repeat, hopefully there will be something new that you go, I don't remember that from yesterday. I must remember this. So my argument for nursing research is that we are very interested in the best evidence-based practice. Okay? As nurses, we're very interested in what works in the real world, what really works for our patients in the real world. When we're moving from randomized clinical trials are something that is much more strict, because what we're doing is we're saying, does this intervention have an effect? Pragmatic clinical trials is there effectiveness of the intervention in real life setting? And why this, I think, is particularly important for nursing is that when you think about a randomized clinical trial, we aren't reaching patients with complex comorbid problems and those most in need. Okay? Because what we're doing is we're saying, okay, for those people with only cardiac disease at only this stage, and so on and so forth. But that isn't often the patient that we're seeing. Also, randomized clinical trials or traditional research rarely happen in typical clinical settings. Certainly, we recruit from a typical clinic setting, but it isn't part of normal clinical flow. So findings often aren't feasible, okay, your feasibility there, for real world uptake. So when we go to a normal clinical setting, okay, they say, we can't do this. This is too disruptive, for our normal clinical flow. We would need to add 3 nurses to do this intervention. We would need another person that is collecting data. This isn't possible. You're going to completely disrupt our clinic, and we can't do this. And we aren't asking questions important to providers, patients, administrators, or policymakers. So again, RCT research is often not relevant to practice. And again, this is what I keep coming back to, is we as nurses, if we want more evidence-based practice, we need more practice-based evidence. So I really want you to think about moving towards pragmatic clinical trials. So traditional RCT study the effects of a treatment delivered to carefully selected populations under ideal conditions, and this makes it difficult to translate the results to the real world. And research has shown that it takes 7 to 10 years from RCT research into clinical practice. 7 to 10 years, that's a long time. Okay, I think we as nurses want to affect clinical practice a little bit more quickly than 7 to 10 years. Especially me, who is getting a little closer to retirement. So, okay, so let's look at a little bit more this trajectory, okay? Because this is a model that kind of shows you moving past the orbit model. The orbit model got us to this box here, okay, this dash box, okay, but it didn't get us past. And so we're going to talk a little bit more about pragmatic clinical trials, and then we're also, my argument is, what we want to do as nurses is we want evidence-based practice, which is pragmatic clinical trials, and then we also want implementation studies. We want to implement interventions that work in real-world clinical practice, and that's implementation studies. So, when we think about pragmatic clinical trials and implementation studies, we need to have partnership to support faster, more relevant research. Okay? The turtle that's just slowly moving onto the screen is your RCT. Okay? That's your slow turtle, the 7 to 10 years. We want to take that slow turtle, strap a booster rocket on him and some wheels. Okay, and as nurses, we care about safety, so we're putting a little helmet on him too. And we're going to work together with partnership with healthcare systems to offer an opportunity to transform research, speeding the movement of scientific discoveries from the bench, from the RCT to the community and to relevant practice. Okay, so pragmatic clinical trials are specifically designed to improve practice. They take place in settings where everyday care happens. You're collaborating with providers and organizations because that is an integral partner to your research, and pragmatic partnerships engage at multiple levels. So you're not just engaging at the patient level anymore. You're also engaging at the provider level, at the organization, hospital, or community clinic level, and then also with certainly what you do is get the key stakeholders involved. So that at the hospital level or the clinical level, clinic level, that might be the administrators. At the community level, it would be community partners. So some of these core characteristics of pragmatic clinical trials is that you're interested in questions from the stakeholders. So these are questions that come from the community, from the patient, from the administrators. Usually what you're doing is looking at multiple outcomes important to decision and policymakers. What do they care about? Okay, what does the community care about? What do the patients care about? You're looking at diverse, representative populations. And what you're doing is looking at real world conditions, not placebo or no treatment. So it's usual care. And then usually you're looking at multiple and heterogeneous settings. So the questions to ask is it important to us, meaning the stakeholders? Is it important to us? For pragmatic clinical trials, you and your colleagues help formulate the research questions. Can we do it here? The study is built around normal healthcare operations. Will it take us more time? For a pragmatic clinical trial, we need flexible study protocols that minimize intrusion in the clinic or hospital or community workflow. And will it help patients? The study explicit goal is to give you evidence that improves patient care and clinical decision-making. Here's another table that I like that I think summarizes the key differences between randomized clinical trials and pragmatic clinical trials. So if you look at the goals, the goal for a randomized clinical trial is to determine the effect of the treatment. But with a pragmatic clinical trial, it's to improve practice and inform clinical and policy decisions. The design with the randomized clinical trial is to test the intervention against placebo using rigid study protocols and minimal variation. However, usually a pragmatic clinical trial tests 2 or more real-world treatments using flexible protocols and local customization. The participants for a randomized clinical trial are highly defined and carefully selected. And with a pragmatic clinical trial, it's more representative because eligibility criteria are less strict. The measures for a randomized clinical trial, again, require data collection outside routine clinical care. And with a pragmatic clinical trial, it's brief and designed so that data can be easily collected in clinical settings. And the results with a randomized clinical trial are rarely relevant to everyday practice, whereas a pragmatic clinical trial is useful in everyday practice, especially clinical decision making. So I find that this chart does a really good job kind of defining, what are the key differences between a randomized clinical trial. And some of the benefits then of the pragmatic clinical trial is that it certainly is practical. It's inclusive because you really take more people. So it's a diverse population receiving care in real world settings. Engaged. And this is important because you already have buy-in before you get started from the key stakeholders. The health systems, the providers, and the patients are all involved in the study design, the collecting of data, the interpreting of results, and the acting on findings. So you already have that buy-in. And then it's relevant because results are designed to directly inform decision-making for all the stakeholders, the administrators, providers, patients, and policymakers. Some of the common features is we often use electronic health records. And the reason being is I just said, we have to do these studies that doesn't disrupt clinic flow. So for me, because I'm often interested in pain, okay, in a hospital setting, pain is measured as the 5th vital sign. So they're already collecting this data. So I can implement an intervention, but not ask anything more for data collection because pain is already in the electronic medical record. Okay. The other thing is randomization of treatment alternatives based on normal healthcare operations. So what this means is that we often do what's called cluster randomization, i.e., we implement an intervention on a whole unit or in a whole hospital, and then we compare with a unit or a hospital that hasn't yet received the intervention. Okay, so this would be a cluster randomized clinical trial. Would be the randomization based on normal healthcare operations. So. Yeah.
This is the point. For the cluster randomization, I think it would be good, but with the hierarchy of healthcare, so should we select the same site of the hospital or the same level with the accreditation?
So that depends on your design, but yes, if you can. But what what I do is that it's very hard to match like that, okay? Because maybe only 2 hospitals in your area have magnet status, okay? So what you do is stratify then, which means that if you have one with magnet status in the intervention group, then you have one with magnet status in the control group, or the one not receiving the intervention. And then you go to community level hospitals that maybe don't have, magnet status, that are a little bit lower in terms of, what they're able to handle in terms of acuity and that sort of thing. So then again, I would stratify so that the community hospital, we would have one in intervention, one in control. And then I'm using the American example of kind of high hospitals here. If you go to critical access hospitals, this is very small hospitals, like maybe 30 beds, out in the rural community. There again, you want to stratify so that if you have 2 critical access hospitals, you want 2 to be, in intervention, 2 to be in control. So what you want to do is balance or stratify the type of hospital. Yeah, when you do that. Yeah, excellent. Because if you're comparing a magnet with a critical access hospital, yeah, that doesn't work very well. So that's how I would do is stratify. And we do that. Sometimes we stratify for patients as well when we randomize. And stratifying, you can also say matching. Okay. When we know there's key variables that are going to make a difference, then we stratify or match, based on, and I'll just use oncology, based on cancer stage or age or gender, sex, those sorts of things. So with hospitals or units, you would use the same thing. Yeah. Excellent question. Okay. Another this is another characteristic just to show the difference between a randomized clinical trial and a pragmatic clinical trial. Again, to talk about the fewer participant exclusions that you wanted for a randomized clinical trial. You want to have a very strict exclusion criteria. And then for a pragmatic clinical trial, you want to have more of a broad inclusion criteria. Yeah.
And when we talk about pragmatic control trial, it's kind of we think about external validity. So how can we bridge the gap between when we decide to ascertain how much strict it is and how to balance internal validity and external validity when we decide the pragmatic control trial to make sure that it's possible to transfer and implement in a real world system.
Yeah, that's a good question. So, and I'm not going to answer your question right now, if that's okay, and I'm going to put it in the parking lot and come back to it. Would that be okay? Because this next slide shows that usually things aren't purely RCT or purely PCT. I've been making the point by contrasting them, but quite honestly, usually there's a continuum. Okay, so pragmatic clinical trials are not an abandonment of the scientific methods that have led to countless breakthroughs. They don't take away from randomized clinical trials or diminish the importance of traditional RCTs. but we need to have a balance, which is kind of what you're asking a little bit. So no clinical trial is completely explanatory or pragmatic. They exist on a continuum, and the way you decide is, do we need to answer the question, can an intervention work under ideal conditions, i.e., do we need to know more about, does this intervention work? Or do we need to know more about, does this intervention work under usual conditions? And that's kind of how we decide actually between internal and external validity as well. So when we think about this, this is one way, and actually the recommended way to decide whether or not you want to be more RCT or PCT and on that continuum. And this is PRECIS, okay, PRECIS, a pragmatic explanatory continuum indicator summary. And this is when I submit a grant to the National Institute of Health, I always answer these questions to determine whether or not I'm calling it a RCT or a PCT, okay? Because it depends where I am on the scale. So I look at my eligibility criteria. How broad or narrow am I? Intervention flexibility. Am I really flexible, or am I saying, okay, you have to come to 7 sessions in order for me to be, and you have to come every week to my session. The practitioner experience, is this a nurse that you have trained to deliver the intervention, or is this someone in the clinic who can deliver the intervention? The comparison, is it a control condition, or is it more usual care? The practitioner experienced, the follow-up intensity, your primary outcome, welcome. Your primary outcome, your participant compliance, this would also be engagement, and the primary analysis. So what you want to do is kind of look at this to determine how randomized or practical it needs to be. So that's how you would decide whether or not you want to focus on the external or internal validity. Did that answer your question a little bit? That's why I put it on the parking lot, because it was like, oh, I didn't pay her to ask that question at that time, I promise. So, and then again, the benefits, I'm wrapping up here about pragmatic clinical trials. And yeah, it's almost 3:00, so this is going to be a good breaking point. The benefits of pragmatic clinical trials for practice is that they're actionable, designed around application to practice, they're patient-centered, and they're relevant. So with that, I'm going to pause here and let's take a little bit of a stretch break, because you've been listening to me for an hour and a half now. And it's 3:00, but we're together. We can be together till 4:30, right? Okay. So why don't we take a little bit of a stretch break, and then we can come back, and I do have more slides and more of a presentation, but we can just go into discussion about how to collaborate on research as well. So we can pause here and just talk about collaboration for the next after break. Does that sound like what you would like to do?
Slide there, because I wanted to.
Oh, okay. No, that would be great. But I want to value your time and value the reason we're getting together this afternoon is research collaboration. So I want to make sure that we have time for that as well. I don't remember how many slides. We're talking about dissemination implementation next. So we're talking about implementation research and the importance of implementation and dissemination research. And I can go through these a little, and then this is the end, is the hybrid designs. The hybrid 1, 2, and 3, which is effectiveness, pragmatic clinical trial, implementation, hybrid designs. And that's the end. But what I'm hearing is that what I haven't heard here at Chiang Mai University is that you aren't at pragmatic clinical trials yet, and you aren't at dissemination, implementation, and hybrid trials yet. So my goal, quite honestly, is giving you a little bit of a encouragement push to move towards more of these designs in the future. So, yes, I know you will. But why don't we take a break? How long of a break would you like? Shall we say, huh? How about 10? 10 minutes? Meet back at quarter after, and I'll go. You have these slides, don't you? Haven't they been sent out? Yeah, okay. So with your permission, what I'll do is go a little bit more quickly through these slides, because you have them that you can refer back to. Does that sound okay? And then, but then also just like the first hour and a half, anytime you have questions, just, say. Does that sound like a okay way to? Okay. Okay, good. Because about this time in the afternoon, I need to make sure that I have coffee because my jet lag starts kicking in. So I need to move around a little bit and have some coffee. Because as you know, at about 5:30, 6:30, 7 o'clock, then we're going. Actually, it's getting better. Yeah. Yeah. So. Yes. So I'll run to the restroom and. Welcome. So, yes. You beat me to it.
I introduced yourself 2 days ago. I used to meeting before. Yeah, my name is Yosapan Namsong. I am instructor, nurse, medical department. Yeah. My specialty is I interested in sleep quality in coronary artery disease adult and gerontology. Yes.
Thank you.
Thank you.
And I'm happy to see you again.
Hi, we meet, we meet again too. My name is Jindaporn Paruthai. I am instructor nurse too. My interest is the lot about it. Like data literacy, like the same, but like more deeply and more meaningful. Yes, for in the older adults. Yes, yeah. Hello, I am Infa Limhan. I'm still studying master degree in Chiang Mai University, and I was interested about stroke survival among elderly. Okay, thank you.
Thank you for joining. So, what I'm going to start talking about now is implementation studies. And implementation studies is when we have determined that an intervention has an effect under controlled conditions. That's a randomized clinical trial. That an intervention continues to have an effect in real life settings. And then what we want to do is study how to implement it or use it in regular practice. So that's what we're going to be talking now about implementation studies. So first of all, I want to show you kind of a little bit about where implementation research goes. And really what it is looking at translating to practice. So what we're doing is we're doing clinical practice related research when we're doing implementation research. And one of the reasons why I'm encouraging you to think about implementation research is that globally nursing researchers are struggling to deliver the benefits of research to their patients in practice and in the community. So it's increasingly recognized that translation from bench to bedside to community is often very difficult and inefficient. So nursing researchers need to focus on how we can get interventions we know that work implemented to improve individual, family, and population health. And that is exactly what implementation science is all about. And so implementation science, I would say, is a somewhat new concept in research in general, but certainly in nursing research. But we're seeing more and more of it. If you just, I would say, if you go to like NIH, the National Institute of Health, eReporter, and take a look at how many implementation research projects there were even 5 or 10 years ago compared to now, we're seeing a dramatic increase now in implementation science that's being conducted. So a definition of implementation science is that it encompasses a broad range of methodologies applicable to improving the dissemination, implementation, and scaling up of effective behavioral, clinical, healthcare, public health, global health, and educational interventions. In summary, any intervention, with a view to improving quality of care and health outcomes, is the definition. There are a number of models of dissemination and implementation studies, but I'm really going to just introduce you to the two most common popular implementation frameworks. There, again, as I said, there's really a lot of them, and you have my slides, so you can go to this link or website that looks at all the different frameworks and models for dissemination and implementation. And they go kind of like when we were talking before about RCTs and PCTs, they with dissemination implementation, they certainly go on a range as well. From broad to operationalized. We were talking about Bill and Barb. Bill is on the broad side. Barb is on the operational side. And then also they range from dissemination only to implementation only and all the way in between. So if you want to take a look at all the different dissemination implementation models, this is the website that I would recommend. I also have www.reaim.org, which is one of the models that I'm going to walk you through. So if you have some time, feel free to go to this website and do some exploring, because this will give you a good idea of all the different models that are out there. Okay, now what I'm going to do is talk about the two most popular. And the first one I'm going to talk about is CFIR. Usually we don't say Consolidated Framework for Implementation Research because it takes too much time and effort to say. We just say CFIR. And again, if you go in and do a PubMed search of CFIR, you will see that, just like what I said about implementation science and implementation research, we're seeing an increase in this work more in recent years. The reason CFIR is one of the two most popular is because it is really consolidated, i.e. Dan Schroeder took a whole lot of different implementation frameworks and combined them or consolidated them all in order to make the CFIR model. So what Laura did was really took the best of the best. She took all the good ideas from all these different frameworks and put them all together to make one. So really, there are 5 pieces to CFIR. First is the characteristics of the intervention. Then we look at the inner setting, the outer setting, the individuals involved, and the implementation process. And so these are the 5 pieces that we look at when we're thinking about whether or not we can implement it. Okay, so this is what we need to assess. The intervention characteristics that we look at is the intervention source. Is it something that we can build? Is it something we can buy? We look at the evidence, strength, and quality. Certainly we want something that has, hopefully, a meta-analysis showing that it is an intervention that has been tested a few times and we know. We want to know what its relative advantage is. I mean, if it doesn't have a whole lot of advantage over usual care, we certainly aren't going to try implementing it. We need to know about whether or not it's adaptable. Is it more at the RCT level where you have to be really strict, or is it something that is a little bit more flexible? How complex it is, the design quality, and then here for implementation, cost. Even though this is the very bottom one, when we're talking about implementation and you're going to a hospital, the first thing the administrator is going to ask you is, how much does this cost to implement? The next piece is the inner setting. So what you want to do is take a look at, okay, if you're going to a hospital floor or to a clinic, take a look at the network and communication. What is the culture there? And specifically, the implementation climate. Okay? Do they like change? Okay, if the answer is no, then you aren't going to be able to implement. And that's why implementation science is so important for getting an intervention implemented or used in clinical practice. That's why we need to think about this a little bit more. And I would say nursing science needs to move to this because, again, if we want evidence-based practice, we need to get the new interventions that have an evidence-based into practice, which is implementation science. Yeah. So we have to take a look at the readiness for implementation. Is the leadership on board? Are the resources there? And we want to take a look at the characteristics of the nurses, of the knowledge and beliefs, their self-efficacy to implement. So the inner setting is, how challenging you saw. We look at the intervention, but then this inner setting is very important too. Then we look at the outer setting. So we look at the patient, their needs and their resources, their degree of networking, the pressure from competitive or similar external organizations. So this is one thing that I have used to my advantage, honestly. It's like, well, this hospital over here that has magnet status is doing this. If you want to get magnet status, then you want to implement this intervention. So, and external policies and incentives. So that outer setting, that pressure from the outer setting. Processes. What you want to do is take a look at how much time you need for planning, engaging. So I have an implementation study going on right now, and it's in the second year, and we're looking at 6 different clinics. And I have one clinic that was an early adapter, and so they're engaging and executing right now. I have another clinic that's still in the planning process, again, because they're inner setting barriers saying, no, we don't want to try something new, Yeah. So these are all things we need to think about for implementation science. So this is kind of putting it a little bit together in a pictorial way. Okay, when the local reality is really that it's almost like riding a bike on a tightrope. And then you have a big valley that you have to try to cross, and then go through a forest, and then you have to, take the gondola, and then you have to go on a boat. So in summary, the local reality of implementation is challenging. From innovation to
maybe forward between roadmap. We are right somewhere else. And they're like, okay, that's somewhere else.
Yes. The second most popular implementation framework is REAIM. So I want to introduce you to that as well. And this is in REAIM again is an abbreviation of reach, effectiveness, adoption, implementation, and maintenance. And I think one of the reasons that REAIM is goes a little bit further than CFIR is that it does focus on the maintenance, where CFIR really stops at, the implementation thereof. So reach is, how do I reach those who need this intervention? Effectiveness is, how do I know my intervention is working? Adoption is, how do I develop organizational support to deliver my intervention? Implementation is, how do I ensure the intervention is delivered properly? And maintenance, how do I incorporate the intervention so it's delivered over time in the long term? So when we break this down, okay, this main question of reach is, who will take part? How and where will you reach them, and how will you know if those who participated are representative of the intended target population? So you want to kind of think about, who do you plan to reach? Define the intended target population. How will you advertise and promote the program? Who needs to approve these methods? How will you know if you reach them and who participated? What methods will you use to attract underserved populations and focus on health inequities? And what information is available to determine that the sample is representative? So that's reach. So reach is the absolute number, proportion, and representativeness of the individuals who participate in a given program. So that's really how we measure the reach. There are a number of strategies that you can use to enhance the reach of your program, and all of these strategies can be summed up in 2 words: advertising and outreach. So the next one is effectiveness. And the key questions here, and again, the ones bolded are the most important to consider. So I wanted to, highlight these for ease of, popping out for you so that you see what's the important ones. What are the most important outcomes you expect to see? For example, more physical activity, which is one of your outcomes. Weight loss, better quality of life, less drug use, improved quality of life. And then the probes and the follow-up questions here is, what is the targeted individual level change? How do you measure the change? This I probably should have bolded this one, but one of the things we really want to think about with implementation science is, who will care about the outcomes. So I'm going to pause here and talk a little bit about my own experience with implementation science, and talk a little bit about pain management. So who cares about the outcomes? One of my interventions for pain management was something called telepain, where we were helping to manage chronic pain patients, complex chronic pain patients in the community, because in the community there wasn't pain specialists. So we linked through Zoom, is a platform you can use, to chronic pain specialists in Seattle with all these community hospitals. And we found out the intervention worked. Okay, we were better able to manage the pain, and more importantly, we were better able to manage decrease in opioids out into the community with telepain. So who cares about these outcomes? Number one, insurance companies. Number two, the state government, because the state government pays for disability. If chronic pain, like I'll just use chronic low back pain. If chronic low back pain is the number one reason working adults leave the workforce and go on disability. So if we can keep young adults working more, then the state isn't paying for disability. Also, what the embarrassing situation in the United States was that there was more deaths due to opioids than automobile accidents. So if we decrease the use of opioids, then we have a healthier America. So for implementation, I was able to get the state government to put in the budget for the state budget funding for telepain. So thinking about who will care about these outcomes is important for implementation, because you want to be able to make your case to major stakeholders. So for hospitals, think about, okay, what are the outcomes they care about? It may be patient satisfaction. It may be falls. It may be, so think about that a little bit more. And how will you share these outcomes? And how likely is it that your initiative will achieve these key outcomes? So these are some of the things to think about in terms of effectiveness. So effectiveness is the impact of an intervention on important outcomes. And this includes potential negative effects, quality of life, and costs. So I was able to show to the Washington state government that they would have decreased costs if they invested in my intervention and implementing my intervention in the state. The next one is adoption. So here the key question is, what settings or organizational types are you targeting? Are you targeting schools, clinics, community settings, or organizations? I have an asterisk here. How many of these settings and organizations do you estimate will use your program or participate in the intervention? And then also you need to really think about who will deliver the program, the intervention, and do they have the time and the skills to be able to do it? So think a little bit more about the expertise or the characteristics of who you are wanting to deliver the intervention. The next is adoption. No, this is a summary of adoption. So adoption is the absolute number, proportion, and representativeness of settings and staff who are willing to offer a program. Think of adoption as reach at the organizational level, setting or intervention delivery agent level. So that's what adoption is reach is the individual and adoption is the organization. As you develop strategies to improve adoption, think about what you can do so that decision makers will buy into this at the organization, clinical, or community settings. Okay, now next, implementation. So here what you want to think about is, how will the initiative be delivered, including adjustments and adaptations? To what extent will the key aspects of the program or policy be delivered as intended? And really important is what costs and resources, including time, because time, quite honestly, is cost, is needed to be considered. And then a follow-up question to this that's really important is, are the resources available and reasonable to ask for? Is this a high enough priority for the hospital administrators, for the state, for whoever, that they're going to invest in the resources to implement your intervention? Okay. So in summary, implementation is referring to how closely staff members follow the program that the developers provide, and this includes the consistency of the delivery as intended and the time and the cost of the program. So once you have developed a program or an intervention that works, reaches the target population, and is adopted by the delivery organization setting our agents, it is important to provide enough support to ensure that the program is rolled out as intended. So there needs to be usually some training of the staff, and then some way to continue supporting them. So every now and then, if they get together as a group to discuss challenges and to discuss what is going well, those are some of the things that you want to think about here. Many strategies to improve implementation are very similar to those listed for adoption. And then, as I said at the beginning with REAIM, I think this is the maintenance is where it's better than CFIR. CFIR doesn't really focus on the maintenance, and so REAIM, I think, is better in this regard. So what will happen over the long term? Can organizations sustain the initiative over time, and are there plans to leave trained staff in place? And how likely is it that your initiative to produce lasting effects for individual participants? So these are some of the things that you want to think about with maintenance. And the reason I'm talking about maintenance and highlighting it again is that just implementing a program, I think, isn't enough. What you want to do is make sure that it can be sustained or maintained. So thinking about how you're going to do that. Because if you think about like a randomized clinical trial, when you're showing whether or not an intervention works, well, what normally happens is once the trial is done, once you're done with your dissertation, once the funding is over, it's over. So I think, and this is why I'm encouraging this so much, is that I think we as nurses really need to move beyond the RCT to think about PCT, but also really think about implementation science. Because I think this is really where, as nurses, we're going to make the biggest impact, is when we actually get our successful interventions implemented and maintained in clinical practice. So in summary, maintenance is the extent to which a program or policy becomes part of routine organizational practices and policies. So within the REAIM framework, maintenance also applies at the individual level. At the individual level, maintenance is defined as the long-term effects of a program on outcomes after 6 or more months after the most recent intervention contact. So it isn't that you've done your RCT and have left, but it's long-term effects and that it continues. Okay, and I'm going to close what I'm talking about today with talking a little bit about hybrid designs. And these are effectiveness implementation hybrid designs. And this is, I think, something also that we're seeing more and more commonly in nursing research is as we're moving to more pragmatic clinical trials and implementation. These hybrid designs are good because they're combining elements of clinical effectiveness and implementation research in one study. So if you look at my grants right now that I'm funded on, 2 of them are hybrid 1 designs. One of them is a hybrid 2 design, and another one is a pragmatic clinical trial. So I don't have any right now funded research that is a regular randomized clinical trial. So I'm going to close talking about the types of hybrids. And there's hybrid 1, hybrid 2, and hybrid 3. I'm going to just click ahead. Yep. So hybrid 1 is where we're focused a little bit more on the pragmatic clinical trial or the effectiveness research. So I would say 75% is focused on the effectiveness research. So what you're doing here is your main aim of the study is, does the intervention work in real life setting? So it's looking at effectiveness, and that's where the focus is. And then 25% is looking at implementation. So if I know this is effective in real world settings, then I'm going to describe how I can implement it in the future. So that's a hybrid 1. Hybrid 2 is 50-50, if you want to think about it. 50% is effectiveness research, 50% is implementation research. So your aims are equal weight. 50% of your effort is going to be, does this work in real world settings? Is there effectiveness of this implementation in real life settings? And 50% of your focus is, how do I implement this in clinical settings? Hybrid 3 is 25-75. So your primary aim for a hybrid 3 is, I'm focusing on implementation. So I'm focusing on the inner setting, the outer setting, the what is the intervention like? Those sorts of things. We're focused really on getting it into clinical practice. So we're not on only 25% is, does this have effectiveness? Effectiveness really has been mostly proven, and maybe this is just translating it into a new setting or something like that. And we're really focused on implementation. So these are the types of hybrid designs, and I would say these are popular because, again, they have aspects of both effectiveness and implementation. So this is really giving you really what I just said, but looking at research aims. So the primary aim in the hybrid 1 is determine the effectiveness. The primary aim for hybrid 3 is determining the impact of implementation strategy. So you can see they're flipped between a hybrid 1 and a hybrid 2. Okay? Because hybrid 1, we really are only just understanding or describing the context of implementation. But when we get to hybrid 3, we're really focusing on the impact of implementation. And the secondary aim for hybrid 3 is really only looking at clinical outcomes associated with implementation. So with that, I'm going to conclude and we'll open it up for more discussion. But thank you really for this opportunity to really talk about building a program of research, starting out with the systematic review and moving all the way through implementation and dissemination.